Afternoon to all. Happy to see you again. Today we are going to discuss on management part 2 about pain. So last week we had discussed about the WHO analgesic ladder, step 1 and step 2. Today, step 3, that is on opioids, strong opioids. The session will be handled by Mr. Sudip Rudrapaul. You all know him, who was our last week faculty. Welcome back and over to you, Sudip.
Thank you. So I'll be requesting two things. One is if you have any difficulties, you can put it in the chat box. At the end of the session, we can address. And one more request, my network is a little bit unstable, so I'll keep my video off so that you all can hear me properly.
Yeah.
So I'll be sharing my screen. Just confirm once you can see my slides.
Yes, sir. It's visible.
Yes. So good afternoon all. So today we will be discussing on the pain management part 2. In our last session, we have discussed about the pain management 1, and there we have discussed about the 2 steps already, step 1 and step 2 drugs. So I'll just recap so that you could remember the things. So there was the little pharmacological strategies to control the pain, like the pain medication has to take by the clock. So whatever the doctor has prescribed the timing to take the medication, the patient has to, or the nurse has to administer the pain medication on the specific time. So by the ladder, so we have to maintain the WHO analgesic ladder so that the ladder drugs should not be overcome. And third is by the class. So we have to see that the 2 same class medication patient should not get at a time, so that instead of getting the good effect or good result, we should not impose the patient to develop side effects. And attention to details, there are little more attention, like some of the factors like their positioning and how they are maintaining their mobility. So these are the things also give the consequences to increase the pain. So these are the things we need to keep in mind. So there was 4 steps in the WHO analgesic ladder. So step 1 and step 2. Step 1 is the non-opioids. Step 2 was the mild opioid. And now we will going to discuss about the step 3 drugs. So can you remember that names of the drugs in step 1? Can you put it in the chat box? I'll request all of you to be active in the chat box. I want this replace. Yes, ibuprofen, paracetamol. Yes, good. Any other things? NSAIDs. Yes, all kinds of NSAIDs are included in that step 1. So step 1 has little side effects, like step 1 can for the kidney function impairment or liver function impairment patient, also those patients, those who have the little platelet or platelet disorder. So this kind of patient, we should not give more of NSAIDs if it is not very indicated. So step 2 drugs, can you please remember? One person is telling that he is not able to see my screen.
It might be the network issue from his sensor. Your screen is clearly visible.
So yes, so codeine, dihydrocodeine, tramadol, and tapentadol. Okay, tramadol, tapentadol also is there. So tapentadol also used to come in the Topal 50, in the name of Topal 50. So it's available in the market. So these are the drugs under step 2 drugs. Okay, so what are the things we need to remember? one of the is that step 2 drugs and step 3 drugs we should not use at a time, because they have agonist and antagonist effect. It's like ADM nurse and PhD nurse in working for a same person, they are fighting among themselves and nobody is taking care of the patient. Okay, so I like you might be remember my example that day. And second is step 2 drugs are should not be used at a time, so that it should not give the side effects to the patient. Next, like we should not use the step 2 drugs in the children below 12 years of age. Now, so what are the step 3 drugs? Can you please write it in the chat box? Morphine, very good. Next, fentanyl. Next, no, oxycodone is weak opioid. Okay, we are talking about strong opioid. Fentanyl, very nice. Hydromorphone, yes. So there are, thank you so much those who have actively take participation in the chat box. So let's begin with the slides. So basically we have step 3 drugs. It's available like buprenorphine, morphine, fentanyl, methadone, sometimes hydromorphone or pethidine. Okay. So what are the nurse's responsibility? So oxycodone, but we have oxycodone, which is strong opioid. But oxycodone is considered as a weak opioid only. Okay, for Zafar Nurul, I like to give you that oxycodone is considered as a weak opioid only, but it's because it has the similar effect of positive and negative. Like what to say, it's like agonist and antagonist effect. So because of its antagonist effect, if the people used to not getting the much effect from the oxycodone, so it's considered as a weak opioid only. Okay, so okay, we'll discuss more in the later. So first is repeated reassessment. It is required for the patient, those who are getting strong opioid. Second is family teaching. Why? Because we are sending the patient, or patient may not be every time admitted in the hospital. So if the patient is going to home and next time if they are coming to the OPD, so what is happening to the patient, how much it was effective for the patient, the treatment, and the how many time the patient took the SOS medication, that the patient or the family members has to give you the history, or the medical team has to get the history from somewhere. That's why family teaching is important in order to give the effective treatment to the patient. Next is the patient, we have to ensure that the patient who is getting the weak opioids or any kinds of opioids, the patient should get the stimulant laxative, because opioids works on the central nervous system, and because of that they reduce the peristaltic movement or gut motility, and because of that patient has very oftenly complains about the constipation. So that's why they need the laxatives. But there are 4 kinds of laxatives, but they need the stimulant laxative, which will give the stimulant of 2 things: mush and push effect. Mush is which will make the hard stool as a cream, and push it, the explanatory force it will induce. Next is when we start the first time with the strong opioid, the patient basically maximum the patient experience little bit of nausea, vomiting, excessive sleeping, or some of the other symptoms which is little bit mild, and they usually subsided after 5 to 7 days. So we need to just inform them so that they should not get worried about that. One is step 2 medication should not be used at a time, which you have like already know that I have already been explained in the last stage. Next, if the patient is transferred from the tablet to patch, so first 12 hours of dose, this suppose patient was on tablet morphine or injection morphine. Now patient wants to go home and we do not want to keep the patient in the injection, or patient is not willing to take the like tablet very oftenly, every 4 hours they are not going to, or maybe they are not willing to take the medication. So we want to keep the patient in fentanyl patch. Whenever we switch the patient from the morphine to fentanyl, it takes approximately 12 hours to maintain the blood plasma level. So for the first 12 hours, we should continue the previous dose of morphine so that the patient should not be on pain. So what are the drugs on the WHO ladder? So non-opioids you have already know. Weak opioids also you are already know. Adjuvants you already know about that. So strong opioids is like morphine, fentanyl, buprenorphine, and methadone. Okay, so we'll discuss about the buprenorphine, methadone, fentanyl, and morphine little detail. Why? So buprenorphine, it's available in the form of patch and tablet. Patch comes in the like 10 mcg and 5 mcg, and while we are giving the patch, so we cannot give the bolus dose because in between the like ongoing medication, excuse me. So if the patient is ongoing medication, because this buprenorphine is basically for 7 days. So within the 7 days, anytime the patient might have this might have pain in between. So we need to give the SOS medication or bolus. But while the patient is applying this patch, we cannot give bolus from the patch. No. So that time we need to give the tablet. So buprenorphine also available in the name of Adnov tablet. Come to the methadone. So methadone is available basically in oral solution or sometimes in tablet form. So but this methadone, there is little advantage and little disadvantage. For the patient who have the like to whom we are giving morphine also, to whom we are giving amitriptyline also, to whom we are giving ketamine also. For this kind of patient who need NMDA, SSRIs, and mu receptor, so these three things are already in one drug. So this drug cannot be. So these drug cannot be can be effect for all three drugs. So it has the NMDA effect on the NMDA receptor, it has the effect on the SSRIs, and also effect on the mu receptor. So NMDA works on the physical thinking of pain. SSRIs is a antipsychotic drug, and mu receptor, of course you know that mu receptor works on the pain. And some disadvantage because of the syrup, because syrup comes in 100 ml, and we every time, like if we just give orally this solution, sometimes this solution is as per the calculation how many doses supposed to come, it is not coming to that many particular dose, and FDA people used to make the issue because it's a they have to maintain the particular register or the calculation of the drug very properly. So in case of methadone, it's little sticky and it's very difficult, and even the bottle inner wall also, it used to be stuck there, and the exact 100,000 ml we are not going to get. So because of that, there must be little difficult. So many of the centers, they prefer to use the methadone tablet. Now come to the fentanyl patch. The fentanyl comes in the form of patch, which is basically works for 72 hours, 3 days. And fentanyl also available in injection form. So it's preferable in case of palliative care. It's preferable to use duragesic in the it comes in the name of duragesic. So duragesic patch, it's It's very useful in case of the patient, like old age patient who cannot remember even how many doses they have to take the morphine. So this kind of patient, duragesic patch is little like good, because once you put the patch, so 3 days the patient do not have to take the tension. But of course the fentanyl patch we have to apply once the patient is in the stable dose of morphine, or patient pain is stable. One, if the patient's pain is not stable, it's with the morphine or with the particular dose of analgesic also, patient is already having the severe, moderate to severe pain. This kind of patient, if we put duragesic patch, our calculation will be wrong and the patient is not going to benefited. And fentanyl patch, over that fentanyl patch is very costly. It comes in the three set of patch all together, and it's cost approximately 2000 rupees. That means one patch itself 600 rupees. Once we put the patch and if it is getting bubbles, so 600 rupees gone, and most of the patient they cannot even afford 600 rupees. So these are the things are disadvantage of fentanyl. And one more thing is fentanyl is a man-making new opioids, which is also known as the synthetic mu agonist. Because of that, fentanyl only works on the mu receptor. So on other receptors that, excuse me. Okay, on other receptors, there is not much effect by the fentanyl. So now come to the morphine. So morphine is basically available in oral form and injection form. So oral form, there are two types of oral tablets. One is IR tablet and SR tablet. IR is instant release, whereas SR is sustained release tablet. And injection comes like sometimes it is the 1 ml equal to 10 mg, sometimes it comes in the 1 ml equal to 15 mg. So it depends on the company, but it available in the injection form also. The point to keep in mind in case of like morphine, that IR works for instant release tablet. It works for 3 to 4 hours, and onset of action starts from the 45 to 60 minutes of administration. Whereas SR works for 8 to 12 hours, and its action start from after 90 to 120 minutes of administration. So whenever the patient is getting any SR tablet, so this SR tablet, it's releasing slowly, sustained release. So it is releasing slowly, and by the time if patient got any kind of SOS pain or like severe pain in between, we have to give the IR tablet only. Because again, if you give the SR tablet, it will take 90 minutes to release and to reduce the patient's pain, and that by that time this 1.5 hours or 2 hours the patient will suffer by pain. So that's why though we are giving the patient SR tablet, but for SOS we have to give the IR tablet as well. And we have to keep in mind that SR or extended release tablets we should not crush, because this it has been come in the coated form, and it's supposed to be blast in the presence of gastric juice, and it will release in a particular manner. Once we crush, first thing is that it is not crushable also, but if somebody crush it by giving effort, and the whole strength of the tablet will release at a time, and instead of getting the good effect or good outcome, the patient may develop side effects, and you know that opioid side effects is little dangerous for the patient. Now, whenever we are using the morphine, there is a little small formula: oral is to subcutaneous is to IV. So whenever just we are giving any patient the oral tablets, it has to be higher dose. where we are giving the IV, we are giving to the direct bloodstream. So it's supposed to be lower dose. So oral has to be 3 mg, or 3 mg of oral tablet is equivalent to 1 mg of IV tablet. And once we want to, if we want to convert the patient from the oral to IV, it has to be divided by 3, because we are going from the higher level to, from 3 to 1 we are going, so it has to be divided by 3. And if we are going to IV to oral, it has to be into 3. So the total 24 hours dose we have to multiply, and then only we can transfer. The thing is that, see, in India, we are, being a nurse, we are not allowed to prescribe the medication, but we are the one who administer the medication. And because to understand, and we need to make sure the doses, calculated doses, are little bit perfect for the patient, and patient should not get any kind of side effects, so that we are not harming the patient. And subcutaneous to oral also is the same. If we are going from subcutaneous to oral, it will be into 2, whereas oral to subcutaneous, if we are going to go, it will be divided by 2. So we need to keep in mind that. Now, coming to the morphine trial, why it is important? One is, sometimes patients come that they are not willing to take medicine. Sometimes they forgot to take the medications, and sometimes this patient came from very far away, and they will not coming again and again. So on the specific time, on the particular time, we have to take the decision, we have to relieve the pain from the patient. So immediately we can go for the morphine trial. This morphine trial, it will, like, those patients who had the poor control with step 1 and step 2 drugs, this patient we can definitely give, or with the particular dose of morphine which has already been prescribed, their pain relief is not good, even they are not taking the medication on time. So that time it is very difficult to calculate the doses. So, and it is important, or it is important for the patient and the healthcare workers also to understand the morphine requirement for the particular patient. It helps the patient for immediate relief if the patient is in severe pain. Now, how we do the trial? So first we have to assess the pain in appropriate scale, which is appropriate for the patient age group, as per the age group. So there we have different pain scale, numerical rating scale, we have other scales, we have face scales. So we have different scales. So on that particular time, so whatever the appropriate for the patient, we have to measure the patient pain, severity of the pain in that particular scale. And we have to remember that first assessment and reassessment we have to do in the same scale only, then only we can compare. Next, what we have to do? So basically injections comes in the 1 ml in 10 mg format. So injection we have to dilute in 9 ml of NS, which the net volume will be 10 ml. 1 ml injection is there, 9 ml NS, it is 10 ml, and injection is 10 mg. So 1 mg solution, and then we have to fix the IV line, and we have to give rapidly, excuse me, so we have to give 1 ml IV, wait for 3 to 4 minutes, then repeat the dose till the time the patient should not get, patient should get drowsy, or patient pain relief should be 3/10 or 4/10 in on that particular scale. So whatever the patient is getting early, if the patient is getting early that drowsiness, then we have to stop there. If the patient is getting the adequate pain relief, we have to stop there. So our net goal is not to make the pain 0, but to make the pain comfortable. It's of course 3/10 or 4/10 in numerical rating scale, what we say. Now, what are the side effects? So if you see the side effects as like other drugs, this universal side effects like nausea and vomiting and itchiness are there. But we can remember the some of the adverse effect or some of the side effects in the format of sacrum. S is sedation or drowsiness. If we increase the dose unadequately, patient may got the sedation or patient may got drowsy, which will be alarming sign for the healthcare workers that we should not give more than that dose. A is analgesia. Of course, any kind of analgesic product we are getting or we are giving to the patient to get the analgesic effect. But if suppose patient came in 7/10 numerical rating scale and I have given 5 mg of morphine, oral morphine, immediate release morphine. So I supposed to reassess the pain after 1.5 hours. Suppose after 1.5 hours, I'm asking my patient, how is your pain right now? And what is the level of pain right now in numerical rating scale? If the patient says that, oh, you have really given a nice medication, magical medication, that my pain is currently 0, I do not have any pain. So this can be a alarming sign for me that one dose is okay, but the particular dose, if I give the patient for continuation, then the patient may develop side effects. So we should reduce the little bit of dose and we should give the patient. C is constipation. In my previous slide also, I have explained that opioids basically works on the centrally acting drugs and it reduces the gut mortality, and because of that constipation is mostly common side effects of opioids. So we should address constipation properly, because if we are not giving the priority to the constipation, then patient will have other associate problems like vomiting and all other. Then it will be very difficult to identify whether it is because of constipation or because of morphine. So it will be very diplomatic. Next is respiratory depression. Now, I'll like to ask you, when you will tell that the patient is respiratory depressed, at what point you will ask? Please tell me in the chat box. Like count RR. Yeah, of course, you are going to count respiratory rate, but how much less respiratory rate will be considered as a respiratory depression? I want the count below 7. SpO2, no, SpO2 is not going to work. Yes, so some of the books it refers that it should be less than, if the respiratory rate is less than 10 breath per minute, we should tell that we should tell that it is respiratory depression. And some books it's referred that 8 breath per minute. So overall 8 to 10 breath per minute, and below 10 breath per minute we will consider it as a respiratory depression. U is euphoria. Euphoria is the excessive feeling of happiness, and U is urinary retention. Because ICU people, they used to use that like torch. No, when we use torch, it will be very difficult to identify whether it is because of morphine or whether it is because of torch. Because if we put strong torchlight to the patient's pupil, it is definitely going to constrict little bit. So we have to take the effort to see the pupil in the room light. And then myoclonus, it's the tonic-clonic jerking of the like myoclonus, it's the seizure. No, so these are the things we need to keep in mind. So if you have any questions, I can see that there are so many things is coming in the chat box. So thank you so much. Okay.
Thank you, Sudip, for the session. Anybody have any doubts on this? Please ask it.
I think one person there, he has doubt with oxycodone and oxycodone.
Yeah, oxycodone. We in India, that oxycodone is not available, but in Malaysia and other countries is available. That is one of the strong opioid.
Okay.
Okay.
Yeah, I have never got the oxycodone. That's why some of
Yeah.
even I don't know. So
Yeah, so we don't have, but that comes under a strong opioid.
okay.
Okay, any other questions? So how do we know about the opioid toxicity? That is one question.
Okay. How do we want to know that whether the patient is having opioid toxicity or not? One thing is that opioid toxicity, these two things that comes in the first. One is patient might have drowsiness. Once the patient is getting opioid toxicity, patient is going to get drowsy, and mucis, this pupil constriction. These two things is going to come first. So these two things will give you the alarm that the patient is going to get opioid toxicity. So we need to keep in mind that, and we have to reassess the things. So
Yeah.
I think it's clear.
Yeah, there are three major that problem will be there. One is extreme drowsiness. The patients will not respond your questions. So that is extreme drowsiness if there is a more opioid toxicity there. And the other thing is myoclonus. So muscle jerky. So myoclonus will be there, jerky movements. And the another one is, as Sudip mentioned earlier, the pinpoint people. So these are the three common things which we can identify whether the patient is having morphine opioid toxicity or not. So if these things develop, then you can think about the reduction of dose. So not stop. You can think about the reduction of dose up to 30 to 50%. If the patient is on 10 milligram for hourly, then you can think about 5 milligram for hourly. That means the 10 milligram morphine, the morphine is not for that adequate, that will be the little bit overdose. So that if they have developed some kind of morphine toxicity, then you can reduce the dose up to 30 to 50%. Sorry.
Yeah,
Okay.
so related to that, there I have got one more questions. Will you be considering naloxone if the patient is in opioid toxicity? So basically it depends, like if the patient is getting long acting any morphine, and I have already like administered to the patient, and then I realized that the patient is in opioid toxicity, that time I have to definitely go to the naloxone. But most of the cases, if the patient is getting IR tablet, so that time if I skip the next dose, obviously it will be like patient will be come back, because naloxone again the patient will be, after coming back to that stage, patient will be in severe pain. So naloxone is not that immediately recommended in such cases.
Yeah.
I don't know that
Yeah,
madam can.
yes. As Sudip said, in my 20 years of experience, I don't have any patient in respiratory depression. If you do it properly, so proper way, there is no morphine that respiratory depression will be there. If there is a morphine toxicity there, you can think about the reduction of dose. That is the management of opioid toxicity. If the dose is too high, that means that opioid, sometimes the patients will be take that particular medications for suicidal attempt. So that is the different management. is going to the depression, respiratory depression, so that time you can use naloxone. Otherwise, that naloxone is not required. And another thing is, if when you will consider morphine, so that also you have to understand. If the patient is not getting adequate pain relief with second step analgesic ladder, then you can think about the strong opioids. Okay, so that means the tramadol medication is not getting the relief, pain relief with that particular patient. Then you can think about oxycodone or morphine or methadone, whatever it is. Okay, so and another thing is, when a patients come to you with severe pain, better you can do the morphine trial. As Sudip said earlier, you have to do the morphine trial and see whether that morphine is giving pain relief to the patient or not. That morphine is giving pain relief to the patient, then you can convert that injection morphine to the oral morphine.
Yes.
Okay, so you can start with the low dose, maybe 10 milligram or 5 milligram for hourly. After 2 days, you have to make a phone call and assess them. That pain, whether the patient is getting adequate pain relief or not, or do they develop any side effects or toxic effect. So over the phone also you can do it. Then you can think about whether you can increase the dose or decrease the dose. The patient is not getting adequate pain relief, then you can think about to increase the dose. If the patient is having any morphine toxicity, then you can think about the reduction of dose. Okay, so there are three major causes of constipation. Major side effects of constipation.
Like,
yeah.
So there is certain calculation which gives you the idea that how much you have to start up dose of morphine, and in case of strong opioid there is no such limit. As per the requirement, body requirement, then we can increase the dose. So there is two questions will come in the mind, that how we will assess. So if you are doing that pain assessment repeatedly, you will come to know that what is the particular requirement, dose of requirement for this particular patient. So we used to increase, or SOS dose is there, so how many SOS dose patient took in last 24 hours. On the basis of that, we increase the dose. So that is one. Second thing, somebody may be having that idea that if we are giving strong opioids, patient might have this addiction. So one more thing I just wanted to clear, that the patient who is having pain cannot having the addiction. Addiction and pain, two things cannot happen at a time. So pain is like a sponge and your pain medication is like a water. If you pour water in sponge, it will absorb, of course. But if you give excessively, then of course there will be some water will be remaining and it will make your bed or that cloth wet. So that's the thing, we should not exceed the limit. So as per the sponge limit we should give, so that there will be no problem.
Yeah. Okay. So regarding the side effects part, I just highlight few things also. Side effects divided into two: adverse effect and toxic effect. Adverse effect is the minimal dose. The patients will get some kind of side effect, that adverse effect, that is mild sleepiness will be there, constipation will be there. One of the most common side effect of opioid is constipation. Nausea and vomiting will be there. Dry mouth will be there. Very rarely itching will be there. Urinary hesitancy will be there. These are the adverse effects of morphine. Okay. And coming to the toxic effect, as I mentioned earlier, extreme drowsiness, myoclonus, and the third one is delirium.
Yes.
And
Yes.
pinpoint people. So these are the toxic effect of morphine. Okay. So when you do the morphine trial, this is the new drug which you are going to giving to the patients, the systemic part. So that patients might develop nausea, vomiting. So you have to give metoclopramide before giving morphine trial.
There is one more questions come. How much is the max dose of tramadol? Tramadol is basically not more than 400 mg in 24 hours. But as like we are from India, so in India,
Sudip? Uh, so, okay, we can wait. So Sudip will answer that question. In the meantime, so one more question is also there. What is the maximum dose of morphine? So, any idea? Anybody wants to answer that question? What is the maximum dose of morphine? No maximum dose. Very good. Any other answers? So, 40 milligram according to pain. Okay, so the answer is no maximum dose, no upper limit. So whatever the dose is needed for the patients, you can increase. No upper limit. Okay. Any other questions? In India, Kerala, we have received an ampule of injection morphine 15 milligram per ml. We usually give injection the morphine trial every 10 minutes, 1.5 milligram. So we take 15 milligram and add 9 ml of distilled water and make it 15 milligram. That is 1.5 milligram per ml. So every 10 minutes, we will give 1.5 milligram, 1.5 milligram. So that means 1 ml. And every 10 minutes, we will check the vital signs, ask the patient's pain score and drowsiness score also. And you can give up to, so the maximum, maybe when you can stop the morphine trial is until the patient is getting satisfactory pain relief, till the patient is getting satisfactory pain relief or the patients will drowsy. So this is the end point of morphine trial. Then you can get an idea, sometimes 4.5 milligram. If you give 4.5 milligram morphine to the patient, that time the patients will get pain relief. Then you can think about how to convert the oral injection morphine to the oral morphine. So we have a 10 milligram morphine. We used to give 5 milligram for hourly. 4.5 milligram we used for morphine trial. That patient is getting pain relief with 4.5 milligram. So then we will start 5 milligram orally. 5 milligram oral morphine to the patient. So if a patient start with morphine 10 milligram for hourly, this is a new drug for them. So how will you educate the patient and caregivers about taking morphine? So I would like to hear from you all. We all nurses, the patients will get, maybe the doctor will prescribe prescribe the patient for that medication, tab morphine 10 milligram for hourly for your pain. So what are the instructions you will give to the patient and the caregivers about morphine? Please put your answers in the chat box. Can't hear? Can you hear me?
I can hear you.
Okay, so okay. My question is, if a patient, maybe the doctor is prescribing 10 milligram morphine to the patient for their pain relief, what are the instructions you will give to the patient and the caregivers about the same? They don't know anything. So you will give the morphine trial and the patient is getting pain relief. And the doctor think like, okay, we can convert the injection to oral morphine. And the doctor said 10 milligram for hourly. That prescription is also he written. The patients get the medication from the pharmacy and come to you and ask you that, sister, can you tell me how can I take this medication? Okay. Set alarm every 4 hours. Okay. Patient should be observed for what? Any toxic effect and side effects. Okay. Please take morphine orally every 4 hours and whenever needed. It is important for your pain control. Okay. Any other things you want to highlight? Okay. For nausea, vomiting, they can take some medications. Very good. Okay. So the first and most important thing is you have to tell the patient about these medications for your pain relief. Okay, not others. Sometimes the other family member will develop a horrible headache. They might be thinking like, okay, you can also take this medication. So this is for pain. So you have to tell them this is for your pain. You have to take it. Not other persons can take it. That's a same medication. And the next thing is they don't know it acts only 4 hours. So you should tell them you have to take every 4 hours. This medication act only 3 to 4 hours. After that, that medication effects will subside. So they should take every 4 hours, and in between they have developed pain. They have to take an extra dose, the same dose, okay, for breakthrough pain. If they have developed breakthrough pain, they can take an extra dose at the same dose. Okay, for example, if they are taking 10 milligram for hourly, in between they will develop pain, they will take 10 milligram as a breakthrough dose. Okay, and the next point is night time. They should take double dose. Otherwise, they will get up in between the sleep. Okay, because of his or her pain. And then you can tell them about the side effects of morphine. So the most common side effect is constipation. They should take stimulant laxatives at night. And regarding the nausea, vomiting, they should take metoclopramide TID for 3 to 5 days, but that is self-limiting. After 5 days, that will be subside. No need to continue the metoclopramide after that. Okay, and the next thing is you have to tell them about the toxic effect also. If this kind of toxic effect like there, delirium, myoclonus, pinpoint people, extreme drowsiness, these kind of things there, they have to inform us. So these are the important things you have to tell the caregivers and patient about regarding the morphine. Okay, and the another thing is better if they can develop in between pain, like breakthrough pain, better they can maintain a diary, pain diary, and then they can for the review period they can come with their diary, and you can get an idea about what is the maximum pain relief is the patient is getting. Then you can think about the increasing the dose of the morphine also. So I think our point is covered. Anything you want to add, Sudip?
One more thing that you have already mentioned, that we have to highlighted them. This medication is only for you, not for your other family members. I have really two examples on that. That time I was very new to palliative care, and doctor asked me to explain, and he was an old man, and I have explained to him that pain medication, how he's supposed to take that morphine, and he used to take that one tablet every 4 hourly, and he went approximately like after 4 days he came back to inform that uh, his wife, she is also an old lady, 65 years of old lady, and she was having excessive back pain, and he has given to that one tablet, one morphine tablet to her, that I am having this neck note, and this one tablet make my pain really good. So this tablet will really work for you also. So you please take. And then after taking, she just wake up after 24 hours. So he came to ask, what is this medicine for? So yeah, this bad experience even I have. That's why it's a really, we need to explain that. And one thing, that whenever we are putting the patch, people basically assume that the body side where I am having pain, I supposed to apply the patch on that particular side. But I'm telling you that whenever the body, any body part, it's aching or paining, that part temperature, body temperature is really increased because of the inflammatory process. And if the patient apply fentanyl or any kind of patches there, so their blood vessels will be dilated, more drugs will be absorbed, and patient may have side effects. So we have to explain that. And sometimes they think that, okay, after applying one patch, within 4 to 12 hours, I have my pain reduced 50%. Let's apply the second patch. So I think I will have the full pain relief. So this also one experience I had. One of my junior staff, she has explained, and she has like marked this very nicely. A fentanyl patch she applied. Like she have marked it, signed it, timeline, everything she has put it, and she asked him to come after 3 days. Date time she has written, and inform him that you please come on that day, we'll again change you fentanyl patch. So he just put it after applying this. So we have given the morphine medicines also, morphine for SOS. So he was thinking, patch is there, again I have to take tablets. What is the point? This patch reduced my 50% of pain. Let's apply the another patch. There is 3 patches already with me. No, so I'll put one more. So he went in wheelchair but came back by stretcher. So this is the actual fault from the nursing side, and so we have to agree that. And so this is the thing, these things can happen with any one of us. So we have to be very careful while we are giving the family teaching, and all the pros and cons we have to explain to them, so that there should not be any kind of accident.
Yeah. Yes, that is very, very important. So if you if you administer fentanyl patch, so you have to give proper instruction to the patient. So otherwise they will remove the patch. So how the fentanyl patches work? So they usually, when you apply fentanyl patch, So usually they make a subcutaneous deposit first. Then only release will the small release will be there from. So the initial 24 hours, the patients will not get much pain relief. So that time the patient will continue the morphine. And also in between the patients will develop pain, they can use the immediate relief morphine. There are two different types of morphine, immediate release and sustained release morphine. Immediate release morphine every 4 hours you have to give, but the sustained relief morphine 12 hours will be there. The action 12 will be there at 12 hours. You can give BD doses. That is enough. So you have to keep it in mind whether the patient, but the thing is that too much expensive. The immediate release morphine is the cost effective, but the sustained relief is release morphine is much expensive. So if they are affordable, you can think about that also. And how will you educate the patient about the discard of fentanyl patch? How will they discard the fentanyl patch? Any idea?
How you are going to discard the fentanyl patch? You are going to change now. So patient change after 3 days. So he or she has applied the second patch. What about the first patch?
Any idea? Please put your answers in the chat box. So what you can do, tell them is the after 72 hours period also that some narcotic effect will be there. So
Yes.
after removing, they have to stick together on the sticky part together. Okay. So then they will
Inside,
inside
fold.
inside fold. Okay, the sticky part together. So that means the narcotic part is not exposed out. Okay, so then they can discard it. Okay.
Okay.
Any other questions?
One more thing, just I wanted to highlight. There is little controversy about the 10 p.m. or night double dose. Okay, so there are little controversy. So I'll just ask you to go with your hospital or your organizational policy only, because sometimes the people think that if I give double dose to the 10 p.m., ultimately this drug is going to work for 4 hours only. So if I go give double dose, triple dose, what, there is no meaning. So ultimately it will work for 4 hours, and after 4 hours it has no function. So there is, what is the point of putting the patient high risk to develop side effects when every one of the family member they are sleeping? So this kind of different questions and controversy is there. So but I like to tell you that whatever is the because we have to think about the patient comfort, because we are palliative care team, so we always prefer to the patient's comfort. So on the basis of patient's comfort, patient feel like okay, if I give the double dose, so at night I won't be feel any pain, and at night I don't have to wake up. And because if uh, like if you give double dose, of course it is not going to work more than 4 hours maybe, but blood plasma level can be maintained little more, so that next morning the patient is not having a severe pain. That's the point. And patient psychologically also it's relieving the patient. So we are giving the double dose only when we can give, or maybe it's practice when the patient is under supervision only. So when it is okay for, then only we are discharging. So it's not going to be a problem.
Okay. And the another one more important thing is the excretion, morphine and methadone. Morphine excretion through the renal system. Because if they have a renal impairment, a renal problem there, you can think about the reduction of dose because the morphine toxicity will be there. The kidney is not functioning well. The more toxicity will be there. So then you can think about the methadone. Okay, so methadone is excreted through the fecal matters. Okay, if they have a renal problem there, you can think about the methadone also. And methadone has two action, nociceptive and neuropathic action. So if they have two kinds of pain, better you can think about methadone also. If they have a cardiac issues there, we don't,
Give,
they are
yeah.
not able to take.
Yeah.
give
But
it.
for that patient, fentanyl can be given.
Yes, fentanyl also.
Fentanyl is
Okay.
a kidney safe drugs.
Yeah. So if fentanyl or methadone is not available, then you can think about the reduction of dose.
Yes.
TID dose for giving that renal failure patients if they have a
basically,
really pain.
sometimes they reduce the dose, or sometimes they keep the like 10 mg. They keep the 10 mg only, but they increase the frequency from 4 hours to 6 hours, or sometimes 8 hours.
Yeah. Okay. We can move on to the case presentation. Zanson. Yeah. Over to you.
I got cut in between and I missed.
Okay. I start. Can you hear me?
Yeah.
Yes.
We can
All
hear.
right. Hi, good evening, everyone. My name is Sansan from Hospice Malaysia, one of the palliative care nurse. Today, I'm presenting a case, a female, 45 years old, diagnosed with metastatic endometrial carcinoma. So the presenting complaint is she reported pain over the right hypochondrial region 10 minutes after taking her meal and described as indigestion with intermittent and duration for a few hours. Onset many months ago, wasn't for the past few weeks on my visit. So the score for pain is 10/10, radiates to the right lower back to the right upper thigh. Described as pricking pain, relief intermittently with fentanyl patch 25 mcg per hour, and aqueous morphine 20 mg PRN, 2 doses in a day. So patient has a similar type of pain of any visit. So if I counted 10 visits, 9 of it is the similar type of pain. So pain titration has done many times due to pill burdens and change different type of opioids and neuropathic agent. The pain is still not well controlled. So for this patient, she was diagnosed with stage 4 endometrial carcinoma, done total abdominal hysterectomy with bilateral cervical oophorectomy. So done multiple lines of chemotherapy via chemoport and radiotherapy. Not well responded. Chemoport removed. Noted left upper arms pain started, and on targeted therapy, lenvatinib, 14 mg daily, and also pain control. So developed left upper limb thrombosis, started on apisapan 20 mg daily, and left upper limb increased heaviness and pain, noted brachial plexopathy. So for this patient, on examination, patient is ECOG 3. Alert chest is clear, no dullness. Abdomen on a sitting position is soft, non-tender. Bowel sound is present. Rectum is noted there's impacted soft stool. Blood pressure was 110/70. Pulse is 93, SpO2 98%. In room S, spine L4 and 5 tender on palpation. Numbness over the dermatom L2. Power is 5/5 over bilateral lower limb and right upper limb. 0/5 over the left upper limb, and sensation is intact. So the assessment tool that we are using on our organization is ISA score, Edmonton Symptom Assessment Score. So pain was 7, tiredness 7, drowsiness 0, nausea 0, lack of appetite was 8/10, and shortness of breath is 0, depression is 9/10, and anxiety is 0. Well-being, she scored 9/10. And so given during my visit, given ecosmorphine 20 mg stat, waited for 30 minutes, pain was still not resolved. So started on subcutaneous morphine 10 mg stat, and abdomen pain has resolved. The score from 10, score 10/10 for pricking pain over the right thigh and buttock area. Given second dose of succulent morphine 10 mg, pain reduced to 2 after 30 minutes. So increased fentanyl patch was 75 mcg per hour, and ecosmorphine 40 mg PRN, and amitriptyline 25 mg on night. The role of emission to rule out possible fracture or Curie cord, the role of emission, yeah. So possible fracture or Curie cord compression. Written a letter to referring hospital and given Revin enema stat. Patient able to BO fair amount of soft brownish stool. Subsequently, okay, patient was on this lenvatinib 40 mg daily, levothyroxine 125 mcg on day, rivaroxaban 20 mg on day, metoclopramide 10 mg TDS PRN, paracetamol 1 gram QDS, amitriptyline 25 mg on night, lactulose 30 ml daily, ecosmorphine 40 mg PRN, fentanyl patch 75 mcg per hour over 72 hours. Psychosocial aspect. She's the fourth child among the 8 siblings and married with 1 kid, 8 years old. She used to be a banker, worked for over 20 years in the same company. She was on medical certificate for 2 years and subsequently resigned. Financially, husband is the breadwinner now. He worked as a freelance wiring man, relying on insurance for treatment. Siblings will visit every now and then. During weekdays, she'll be alone at home. During working hours, so most of the time, 8 to 5, probably she'll be alone at home. But patients still able to self-care. So she will contact friends to pass her time and will call siblings or cousins. ADL, she was limited due to left upper limb lymphedema and pain. Patient feels sad because she has lost her role as a mother and a wife. She enjoys travel, take a lot of photos, and printed it to keep it as a good memories. So my main concern is pricking pain over the right hypochondrial region and lower limb. Summary, Curie worsening of neuropathic pain, Curie bone mets, Curie spinal cord compression, or Curie total pain. So went to hospital, investigated, no fracture or disease progression. Patient has a similar type of pain each visit. Pain titration done many times due to pill burden, change in a different type of opioids and neuropathic agent. Pain is still not well controlled. So I just would like to discuss whether is patient having any total pain and what can I do to make her more comfortable. Thank you.
Thank you, Samson, for the presentation. Anybody needs any more clarification regarding this patient story? Please ask her, otherwise we can move on to the discussion points. So we would like to hear from you all. So how will you manage? How will you? We are going to support Samson for better management. We all contribute something. You have to contribute your ideas.
Yeah.
So I hope the case presentation is clear to everyone. I think we can move on to the discussion points. First question is, what is total pain? Her question is that patient is having total pain? So I would like to hear from you all, what is total pain? So Narul said to explore whether she has existential suffering or not. So what is total pain? This is our the third session on pain. So now,
Total pain means it
Total pain
includes physical, psychological, social, spiritual.
Yes.
okay, physical, psychological, social, and spiritual pain. That is total pain. So okay, so what are the physical problems? What are the social problem? What are the psychosocial, psychological problem and spiritual problem for this patient? Go back. Go back. So she has a physical problem. Previous. She has pain. It's not getting adequate pain relief. She has neuropathic pain. So she is having physical pain. And moving on to the psychological part. So what are the psychosocial issues here? Loneliness, unable to perform daily activities, then unemployment, very good. Financial concerns.
Also it's mentioned that the role changes, like she cannot, she feel very sad because she has lost her role as a mother and wife. So this is really a like indication, and we have to take it in consideration.
Yeah. So now usually she has lot of things because she used to travel, take a lot of photos and all. So these all things is missing because of her disease. And as
Yes.
Sudip said earlier, because of his illness, because of his illness, she is not able to perform her role because as a mother, she doesn't do anything because of this terrible pain, and also because of the she wants to do something for her husband, but that is also not possible now. This will be affecting the patient emotionally and psychologically. So, and also spiritually also, because the patients might be thinking like, why this kind of disease getting? So why God punished me like this? I
Yeah,
am
when the like when the people will talk to her, then only that issue will come up, and then like here it is mentioned that activity in daily living also it's reduced. She cannot perform on daily living activities. So nobody wants to depend on someone else, and so dependency. Financially also she dependent because she was working 20 years in a company, so she was little bit independent. Now she is dependent. So this dependency, it's also a like give her a psychological pain to the to her. So these are the things that we need to like address. So all total pain, when we are thinking of total pain, along with physical, psychological, social, and spiritual. So socially, how she is feeling of loneliness; psychologically, how she is depressed, and maybe the treatment, how much it is effective. Along with that, maybe she has little anxiety factors also, and so these are the things we need to address through counseling. So repeated counseling, we have to talk to the patient's family members, patient's husband, and all the like close relatives. Then only we can address the other all the total component of pain.
Yeah, so so the main point is you have to listen the patient's worries. and
Yes.
explore her concerns, and her maybe some confusion will be there, some misconception will be there, some point is not clarified adequately, that kind of things will be there. So better you can spend time with some time with the patient, if possible, do the individual assessment. If you do it individual assessment, they can she can explore freely. Otherwise, in front of the caregivers, they won't tell the truth. So you have to explore the patient's problem individually. Then you will get a complete picture. So then based on that, then you can support the patient. And also you can think about if she has an isolation, you can think about the volunteer support also. Can find the community, local volunteers or friends or relatives. They can come and sit with her and talk to her, and that way we can engage her. So otherwise she might be thinking, so what is next? What is next? Is there any problem happen? Is maybe my death will come soon? That kind of thing will be there, because nobody is there for take care of my child. These kind of psychosocial issues will be there, and that emotional issues also there. So better you can sit and listen her worries first, and at least if you listen there, once she is able to express her emotions, maybe 50% of things will subside. So sometimes nobody is there to hear her that problems there. So everybody is busy. Even family members also busy. So nobody is willing to listen their worries. So better you can find the time to listen her and explore her problems. So that way, I think at least 50% of problems we can subside. Then you can think about the medication part also. So here this patient is not getting adequate pain relief with opioids. So then you can next. Yeah. So this patient is having neuropathic pain, right, sister?
Yes.
Did she get any medication for neuropathic pain?
Yeah, she was on gabapentin. Initially, we started with BD dose, 300. And then subsequently, we titrated up to gabapentin 300 mg TDS. And the neuropathic pain still persists.
Okay.
Then we changed to amitriptyline 10 mg. Then we titrate again with amitriptyline 25 mg on night. And the neuropathic pain is still persists.
Okay. So I think we can think about the methadone also. These patients, the methadone could help. So here is a nociceptive pain and neuropathic pain will be there. If methadone is available, you can think about that also. Do you have methadone?
Sorry, we don't have methadone in our organization.
Okay. So.
And one more thing, there is a bone mass query, because one thing I can see, I don't know in which slide. There in one of the slides, it's mentioned that she is having little back pain also. So those patients who has the ovarian cancer, they are very prone to develop bone metastasis actually, and secondary to bone metastasis. So in order to find out the bone metastasis, in order to find out the spinal cord compression, we need to undergo like little bit of other radiological studies. Then only these things can be confirmed, and it will definitely impact on the patient's mobility and patient's pain, of course.
Yeah, yes, that is true. Because lot of medications is there, still that patient is not getting pain relief. So that time you can think about the next investigation, radiological maybe investigation also. You have to rule out whether the patient is having any bone mets or something like that. If they have some bone mets, you have to treat accordingly. You have to think about that also.
Yes.
So, and the next thing is you have to give some psychological support to the patients, because a lot of medications, lot of treatment, not getting adequate pain relief, and not get giving a role, maybe not able to provide support to her child and support, that will be affecting the patients emotionally. So better you can give good counseling and psychological support to the patient and the caregivers too. So caregivers, you have to think about the caregiver side also. You have to listen their worries also, because they are also the same feelings. Because a lot of investigations were done, but not find out any problems. But his wife is having pain. So that kind of that worries inside his mind always. Better you can listen his worries also. Okay. Any other questions? Any other questions or any comments you want to first? Then you can add. Otherwise, we can wind up the session. I hope no questions.
At last, there is one thing. Nurul has written one thing. Get admit the patient and titrate with methadone. I like to confirm that there is no titration with methadone. Methadone cannot be titrate. Like one thing, methadone, this drug, the first 7 days, 7 to 10 days, this drug, half of the dose, whatever the dose you are administering to the patient, this half of the dose, it used to store in your subcutaneous tissue. And after 10 days, here you are not getting the sufficient action, and that side from the subcutaneous tissue it will start releasing, and it will go, ultimately it will go like out of control. So that's why methadone is never used for the titration. Methadone, morphine is used for titration. On the basis of morphine dose, methadone dose can be calculated, and first 10 days methadone is administered like 50% of the requirement, or maybe 75% of the requirement. Side by side, morphine will be there for SOS. One, after 10 days also, if the patient is not getting pain relief, then only methadone dose can be increased by 10 to 15% only. This is the rules. This is the formulary says actually.
Yeah. So actually methadone, no need of admission. You can administer the home itself also, but you can start low and increase slowly. So low dose, you can always think about the low dose, and then you can increase the dose. So here also, if you start a methadone, initially the methadone will act in the subcutaneous depot, make a subcutaneous deposit, then act slowly. So till that time, as Sudip said, you have to continue the morphine. So okay. So this is the management. If you want to learn more about methadone, I will share an article. So then you can go through it and learn from that article. So if you have any doubts, please let us know. Thank you.
Thank you.
Thank you. Bye-bye. Thank you.